Hi, good afternoon. My name is Angel Chin, and I am a thoracic medical oncologist at the University of Michigan. It's so nice to see all of you.
Hey, good afternoon. David Spigel. I'm a thoracic medical oncologist here in Nashville at Sarah Cannon Research Institute.
Do we need to read the questions or they can see it? Okay.
So you want to start with maybe Angel? It says I'm 2.5 years into treatment on alectinib, full dose, stable with minimal side effects. However, my bilirubin has been slowly increasing and is currently at 2. What kind of changes, a dose reduction or otherwise, are warranted?
Yeah, I think that's a really great question. I think that we do see a lot of, can commonly see liver toxicities with any of our drugs, alectinib, lorlatinib, brigatinib. I think it's going to be important to first make sure that the elevated bilirubin isn't due to something else. So I think, we always think about the drug, but making sure there's not another underlying liver process that is going on. But I think that if things are otherwise stable from the cancer and this bilirubin has been ruled out from any other cause, I think it's very reasonable to reduce the dose.
You want to take the next question, or
We can just take back and forth.
yeah?
Yeah. So the question to you then is, are you seeing LMD post-alectinib and how to treat and monitor?
Yeah, so LMD refers to leptomeningeal disease, so cancer that isn't just, say, necessarily in the brain itself, but in the spinal fluid. Sometimes the other term that's used for that is called carcinomatous meningitis, and it can be a difficult thing to diagnose, something you can pick up on imaging with MRI, but you may not, and it may require what's called a lumbar puncture, which sounds scary and terrible, but Angel and I used to do those as medical students, so they can be done safely. Right, Angel?
Not right now by me
Yeah,
anymore.
you wouldn't want us to do those
No,
now,
not
but they can be done very safely. And so, yeah, I think LMD or carcinomatous meningitis is a unfortunate complication of any cancer, especially the longer someone does kind of well on a therapy. That is an area we do watch very carefully for and kind of aggressively work it up with lumbar punctures. And how to treat it, though, is it can be difficult. There are therapies that you can inject directly into the spinal fluid, which really we don't want to have to do. Those can be hard therapies. They're chemotherapies. I think what you're referring to or alluding to is what could you do with the drug you're already on, and sometimes what's been shown in other cancer settings like EGFR lung cancer and even in ALK lung cancer is that if you increase the dose, you can get better penetration of that agent. And so I think the options would be to increase the dose of alectinib in this example, switch to another drug like lorlatinib, which maybe that has better penetration. We don't know that for sure, but we know it's very active in the brain. And then to consider other options, whether that's chemotherapy or even radiation in some cases. Okay, and sorry, I'm trying to go in order here. This is good. This is perfect for Angel. How are you leveraging AI, artificial intelligence, at your institution, the University of Michigan, to discover new compounds that can overcome resistance mechanisms in ALK positive lung cancer?
Yeah. So as part of our, ALK research initiative, the GTAM ALK research initiative, we do work with a fantastic medicinal chemist, and he's showing us different molecular structures all the time, and trying to modifying either existing compounds or perhaps new compounds that may be effective in ALK-resistant non-small cell lung cancer or ALK non-small cell lung cancer that's resistant to other treatments. We do now recently have a school of machine learning, so we are starting to use AI and leverage that, and we are recently actually asking a PhD in that area to come join our ALK initiative. So I do think that is very much on the horizon. So the next question for you, Dr. Spigel, is any evidence yet that surgery and or radiation after a great TKI response are beneficial? Thankful for my team for doing both. It helps my psyche a lot to think I'm doing something to help myself. What do you think?
Yeah, I think this is true really across oncology, not just lung cancer or specifically ALK positive lung cancer, to try to use kind of more aggressive approaches for situations where there's metastatic cancer. I think historically there's been kind of this thinking that once cancer spread, it doesn't make sense to kind of go after anything locally with surgery or in this case radiation. But what we do know is for those that are kind of good candidates for that, and I'll talk about who that is in a second, it can be a very effective strategy at extending lives and improving kind of how folks are doing, especially with things like pain. So I think we're all kind of making those judgments based on the patient's journey. So let's say somebody starts out with stage 4 cancer in different places. We want to get disease kind of under control. That may be in a few months, it may be in a few years. And at some point, you might be left with lingering areas that either grow a little bit or causing problems in the form of pain. And I do believe that being aggressive and going after those with usually radiation these days, less often surgery, is a very appropriate approach. And I think there's going to be some folks who have limited metastatic disease where you might even cure them because that limited metastatic site has been kind of definitively treated. Okay, trying to keep up with the order of these, so forgive me if we're skipping a little bit. They keep scrolling. Okay, have either of you seen a link, I don't think I skipped here, between heart failure and either ALK disease or alectinib therapy, or brigatinib therapy, I should say?
So I have not yet personally encountered heart failure as a result of any ALK TKI that I've used. I know that sometimes the other TKIs, especially for EGFR disease, can be associated with cardiac issues, but I have not personally seen that with an ALK TKI. I don't know if you have had a different experience.
I think you're talking really rare percentages here. So not something I usually think about in terms of monitoring or screening or long-term risk, but I'm sure that could happen, but you then start to wonder what other therapies perhaps have been used in someone's care. But in general, I don't think we kind of associate heart failure as a real risk with ALK lung cancer treatment. There's a question for you.
Yeah. So it says, Dr. Qin, is there anything you're able to share thus far about the gilteritinib study? So we recently opened it. It was at the end of April, I think the last day of April, we were finally able to open the study, which is very exciting. And we are actually dosing our first patient next week and screening a second patient next week. So hopefully I'll be able to share some more after that. But we're very excited. And then the next question is, how long can chemo be used?
Yeah, so sometimes chemo is a term that people apply to even oral therapy. I think this might be a question for actual chemotherapy, but let me answer both. So if you're on oral therapy, which is really the standard of care, we continue that indefinitely. We don't usually stop that. That's something we want to keep going as long as it's working and someone's tolerating it well. In terms of chemotherapy, and most often two drugs called carboplatin and pemetrexed or Alimta are used. We do have kind of limitations to how long we'll give those. So carboplatin usually is used between 4 and 6 rounds of therapy. So that's often about 3 or 4.5 months. Pemetrexed or Alimta is a drug that can be continued in what we call a maintenance setting indefinitely. Mm-hmm. And so that is a drug folks can stay on for years even. Sometimes I'll end up stretching the frequency out, so it's not every 3 weeks. It might be every 4, every 6, every 9. But there can be long-term side effects with blood count issues and sometimes edema. And I do have a low threshold for stopping what we call maintenance chemotherapy when I can, just because it is hard to stay on chemotherapy indefinitely. Okay, if a patient contracts COVID and would have to hold their TKI for 5 days to take Paxlovid, the treatment for COVID, because of potential interactions with a TKI like brigatinib, how would you advise them?
So this is a fantastic question. And something we deal with all the time with other TKIs, not just the ALK TKIs. But that is when I turn to my pharmacist, who's been immensely helpful, because sometimes you don't actually have to hold a TKI. We can either do a reduced dose or, holding TKI and doing it every other day. So you don't necessarily need the 5-day hold. with that, so that is why it's really important if you're going to be prescribed a different medication to always let your oncology team know because of that potential interaction in general. With that said, though, if hold is required, I would not fret about it. It's 5 days. We don't really see a big dramatic side effects or loss of efficacy with a very limited hold. And we were just talking about in our other sessions that we have patients who kind of do this alternating therapy, couple days on, couple days off, just for tolerability. So I would not worry about a 5-day hold if that's necessary. Our next question is, why does the U.S. not measure blood levels of TKIs like they do in Europe? I've had serious pneumonitis on 2 different TKIs.
Yeah, it's an interesting question. You're correct. We don't really measure blood levels of drugs for any condition in oncology that I can think of. And the only one that kind of comes to mind is a medication, say, used for seizures, like neurologists will measure levels to see if they're too high, an old drug called Dilantin. But you're correct. In the U.S., that is not a standard of care, a standard for tyrosine kinase inhibitors in ALK lung cancer. I have to admit, I don't know data from Europe that I just need to dig into to see has that been shown to be beneficial in helping minimize toxicity. But you are correct because you've experienced it, obviously. But one of the kind of dreaded side effects of tyrosine kinase inhibitors is pneumonitis, and it can be a class effect. So if one drug caused it, going to another, it's not surprising to me that you might have had a flare in that pneumonitis again on that drug. It's an unfortunate side effect, but certainly a very serious one. Okay, could you please talk about out-of-state patients' involvement in your University of Michigan program? What is the benefit of being part of that research?
Yeah, so we are really thankful for everyone who's participating or thinking about participating. Truly, and all the patients who are here at the summit who've given blood. Our goal with the research is really to try to understand more about ALK. Be able to collect blood and doing some more deep sequencing, try to study if there's any circulating tumor cells, trying to get a sense of what, the immune system may be interacting. I think these are all questions that we all have in general, and I think doing this on a large scale is the only way that we can do it. The research may not be immediately beneficial to, you at this point, but we're hopeful that this will impact ALK non-small cell lung cancer in the future. Out-of-state involvement can be tricky. I understand there's a lot of red tape and between institutions that it's beyond our hands and what our, the lawyers will allow. But we have had patients who are able to, draw blood as part of, like a gift agreement. Doesn't necessarily always require a material transfers agreement. So if you are interested, please do reach out to us and we will find a way, if possible, to have you be involved. So thank you all again. Next question is, what is the best advice on, quote, curing or minimize residual cancer treatment, i.e. vaccine for the ALK patient on TKI for 3+ years and NED without metastasis?
Yeah, what a really great question. I think we're all trying to get to that. It's hard to know. There are other therapies in the treatment of lung cancer, say immunotherapy is a good example, where somebody would be, this term NED stands for no evidence of disease, or sometimes we use the term complete remission, where we do feel comfortable stopping, say, chemotherapy or immunotherapy. And there are going to be patients who are cured after some period of not having disease or being in a complete remission. And that's been true in other cancer types like melanoma. In the oncogenic-driven settings like ALK lung cancer, we have a concern that the drugs are extremely effective at controlling the cancer and keeping the active clones at bay in what's called a remission. But we do have a concern that if you release that pressure, that it allows the cancer to kind of grow again. And so for that reason, unfortunately, this is a therapy that we continue indefinitely. And we have examples in other cancer settings like CML, chronic myelogenous leukemia, where we need to keep those therapies going to keep cancer in control. I think where Angel and I would like to get is where we could get to a point and say, okay, now if we gave radiation or we gave chemotherapy or we gave an antibody drug conjugate, Could we get over that hump and actually eradicate all the clones and just stop therapy and somebody would be cured? We're trying to get there. We're not there yet. Okay, it's just working out perfectly. The questions are bouncing to you. I'm a patient enrolled. This gets to the material transfer agreement. I wonder if we just, since we just addressed that, maybe I'll skip that if that's okay. Sorry.
Just the one
if you
second
wanna
piece.
add to that to
Progression. It says if progression were to occur, can the biopsy and pathology be
perfect.
conducted at University of Michigan and shared with MD Anderson? So the answer to that is yes, absolutely. Actually, Jeff, I think, wrote about his journey where he had progression. He actually came to see us and got the biopsy, and then we shared the results with his local team. So absolutely, if this is something you're interested in, it does unfortunately require you to come visit us in Ann Arbor. I think Ann Arbor is great if y'all haven't been there. But if this is something you're interested in, please reach out to us as soon as you know, and then we will do our best to try to expedite that and absolutely share that with your oncologist back home.
Perfect. I'm glad we didn't skip that question for Dennis. Let me ask you another question here. How common is pericardial effusion in ALK positive non-small cell lung cancer, and then how do you treat that?
Oh, that is a great question. I think, like the earlier question about cardiac toxicities, I think that pericardial effusions is not something we necessarily commonly see, although we can see it. And I think TKIs alone can be a very effective treatment by itself for the treatment of pericardial effusions. I think it also depends on how significant the effusion is and how symptomatic you are from it, because sometimes we'll involve our colleagues in thoracic surgery who'll do something called a pericardial window, basically a little incision to allow that fluid to drain. But I think TKIs alone, because they can treat the cancer throughout the body, can be an effective single agent treatment for pericardial effusions.
I may, one more question from Michigan, if that's okay.
Sure.
I'm 4+ years, stage 4 on alectinib with doing well. I'm treated at Sloan Kettering. Am I a candidate for a biopsy for the study at the University of Michigan?
So our current study is that we are taking the biopsy when it's clinically indicated. So most often that is when patients have suspicion for progression. So I think right now, if you are doing great 4+ years on alectinib, that's fantastic. We wish that continues for a very, very long time. So right now, there really is not a need to do a biopsy. If you are interested, though, in sending blood, we are always collecting blood. Again, we are interested in how someone who's been doing great on 4+ years, what that blood looks like versus someone who may not be, in the same situation. Perfect. So then the next question to you, David, is what do you replace maintenance chemo with?
Well, I guess, so we're talking about a setting where someone probably has been on a TKI, let's just say lorlatinib, and maybe it stopped working, and we're using chemotherapy. We haven't talked a lot about that today in our other sessions. We all practice differently. What I do in that example is I'll add carboplatin and pemetrexed or Alimta outside of a trial, and I'll keep lorlatinib going, actually. And then I'll get to a point where the patient is only on pemetrexed and lorlatinib, and I'll kind of ride that out, but only until I feel like that's as safe as possible. Both drugs can be associated with edema, and so I'll have a low threshold to just drop the pemetrexed and keep the lorlatinib going. I know that's the drug that just stopped working, but if chemotherapy kind of gets things back under control again and addresses the resistant clones, lorlatinib can still be a drug that can offer benefit for some period of time. Okay. When diagnosed as stage 3B first, we have taken chemotherapy for 3 cycles, but it didn't respond. Now we are started on lorlatinib. Does that show we have this bulk or bad ALK lung cancer and show a bad prognosis?
So I don't know that we really know what are the bad prognostic features of bad ALK. I don't think that not response on chemo means that there will not be a response on lorlatinib or alectinib or brigatinib or the other TKIs. I think that we've seen that sometimes chemo isn't for everyone, and that some patients will respond to it and some patients will not. So I don't think that necessarily, that means you will not do well on the lorlatinib. So the next question is regarding potentially stopping a TKI. What's the downside to stopping and monitoring and then restarting if you see activity? That's a great question.
Yeah, these are really good questions.
Yeah.
At the end of the day, I'd have to say we don't know, but I can tell you theoretically the concern is because of the diversity of cancer cells, if you're releasing what's called the selective pressure on the cancer cells that are sensitive to, say, the ALK TKI, you release it because you take a break, and not just a few days, but say you're taking 2 or 3 months off. The concern is that those cells then will start growing again, but perhaps with a resistance mechanism that comes on more quickly because they've already been exposed to the drug to some extent. There's a lot of analogies to this. They're not good ones, Angel. I use a lot of times insecticides. I think
No, that's a
Ross
great
did talk
question.
about
Yeah.
it. And so we like to kind of keep the foot on the brake, or sometimes I say on the neck of the cancer, and not let up because of the concern that you might be helping the cancer become more resistant. And then when you try to restart the drug, it may not work as well. This is all theoretical, but I imagine, Angel, that's your concern too.
Absolutely.
Okay. Sorry, the screen is moving here. Give a shout out to Michigan. There's Ann Arbor, Michigan is a great place.
Go blue.
I will agree with that. If you make your trip there in the winter and go to a game. Okay, another COVID question regarding COVID and brigatinib. I was given a different medication, so not Paxlovid, but the antiviral. I'm going to mispronounce this, Molnupiravir, which doesn't have an interaction and treated in the UK. Just thoughts on that, a different kind of COVID med?
Oh, gosh. I think the most commonly one that we use is Paxlovid. And again, I think, again, I don't know that you have to necessarily always hold it. That's where you talk to the pharmacist about, if a dose reduction or alteration is warranted. But that's great that you were able to get that drug and no interactions with brigatinib. Maybe that's something we should look into. Okay, so the next question is, it was mentioned earlier that TP53 mutation may be a poor prognostic factor with no treatments that specifically target it. If we have this, is there anything that we can do? Is it a reason not to spread out our monitoring scans every 4 months?
Yeah, it's a real good question. So P53 is the most common mutation in cancer, not just lung cancer, ALK positive lung cancer. It's the most common mutation in cancer. Mm-hmm. It's what's called a tumor suppressor gene, and to think of that in a simplistic way, when that gene is intact, it helps prevent cancer. And so when it's missing, it may be the reason, because it's the most common mutation, that cancer develops. If you think about when you're missing something, it's hard to drug that, to develop a drug to kind of replace what you're missing. A lot of our drugs are designed to inhibit a gene that's causing a protein to be made. And so in this case, there are strategies to target cancers that have P53 mutations, but they're very early in development right now. You do bring up a good point, and this is true for a lot of lung cancer settings and in the TKI settings. So I think of EGFR lung cancer. When we see a co-occurring P53 mutation, we do have extra concerns that this may be a poor prognostic factor, but it is not a reason for us to not use a TKI. And I know Angel will say that, like me, we have patients who've done quite well with coexisting P53 mutations. So we're aware of it, but we don't change our strategies at this point. Okay, it's weird how this is working out. It's like perfect Michigan questions. How long do I have to be on chemo before I enroll in the gilteritinib trial? By the way, I am doing okay on chemo.
Yeah, so I think as long as you're doing well in chemotherapy or for others, other treatments, there is no need to jump to a gilteritinib study or any other study, because I think if you're doing well on one treatment, we should ride that out for as long as it's still working and that you're tolerating it. Absolutely, though, if there was an issue with tolerance on on the chemotherapy, or if there's progression, then we would absolutely love to see you and see if the gilteritinib study would be right for you. Next question is MET alteration considered for MET amplification?
Yeah, the terminology can be confusing. So the term alteration simply means that something's abnormal in either the gene or the protein that it codes for. So in the case of MET, there's many different ways that gets perturbed. And so you can have what's called a mutation. The most common one is called an exon, or the most common one that we can treat and do something about is the MET exon 14 skipping mutation. And then there can be other abnormalities in the protein. So you can have overexpression of the protein. You can have amplification of the gene. And the definitions of what is too much amplified, too much expressed is still something we're sorting out. In general, highly expressed MET, in this case, we use a 1 to 3+ scoring system, and highly amplified MET are considered to be settings where a MET-directed strategy, maybe a TKI, maybe what's called an antibody-drug conjugate, can be effective. We're less certain of whether these strategies work in lower levels of expression of that target or amplification. But I'll leave with this. If you're following what's going on in breast cancer right now, there's a drug that's targeting a type of protein amplification expression called HER2. And some of the data with those targeted drugs, specifically an antibody-drug conjugate, show that it works really well in highly amplified tumors, but also in minimally amplified tumors. In fact, our big meeting at ASCO in June just showed that there's a new category of minimally expressed or minimally amplified. It's kind of a made-up term. Where the drug still works, but you don't have a lot of the target. Couldn't that be the case in MET? It could be, but I think it's going to depend on the testing and the drugs. Okay, we got about 6 or 7 minutes maybe. Diagnosed with lung cancer in March, had surgery with a lobectomy just last month with a biopsy that proved ALK lung cancer. Not sure if any other testing was done. How do I approach my doctor to ask about other mutations like MET, et cetera, or p53, and how should I bring up switching to lorlatinib?
That is a really great question. So I will presume that perhaps you are currently on alectinib, as it was recently approved for patients who have post-surgery. So that's my assumption. So to your first question about testing for mutations, so that is a big area I think that we as a medical community, as healthcare, need to be better on, because there are certain panels that are being used which are more limited. So they're not looking for all the different mutations. And then I think more commonly, and I certainly know this is what David and I use, is a much more broader panel of mutations, whether or not they have an indication right now for a drug. So I think the first thing you need to do is to get a hold of your molecular report. I think that is part of your medical record, and that is something you are entitled to, and you should look at it. What is this sequencing report say? Did they only look for ALK, or did they look for other mutations? If it's an expansive panel that's been tested, then the MET should be on there, with the exception of MET expression, which currently is what's called an IHC, which is this different kind of staining, which may not be always reported on these panels. Right now, we don't know what if there is a role for lorlatinib post-surgical resection for ALK positive non-small cell lung cancer, but we have seen the data with alectinib from the ALINA study. So I don't think I would recommend switching to lorlatinib because we don't know about it in this setting, and I think that alectinib is the standard of care in that situation.
There's a question about your study with the blood cancer analysis. Is this in the process of becoming a new standard that would be approved by the FDA? And what is the difference between liquid biopsy and your study?
So we're not necessarily seeking FDA approval right now. Our blood draw is really meant for research to help us understand more. When we talk about liquid biopsy, conventionally as it is now is looking for ctDNA or circulating tumor DNA, for which we can understand the molecular changes that might be occurring most often if patients are progressing, but certainly also if we're concerned about residual disease. The blood analysis that were done at U of M is not necessarily actually doing that. We're actually trying to understand more about the cancer. So we're trying to do deeper sequencing, looking at the interactions with the immune cells that are present, as well as looking for circulating tumor cells, which is a little bit different than circulating tumor DNA. So ours is very much on a research level, whereas liquid biopsies, as they stand today, are FDA approved and we use in the clinic. Next question is, can you explain CDK loss in ALK setting and TP53?
Yeah, so commonly on the reports that were just discussed, when you do broad testing, you might see something called CDKN2A loss or CDKN2B loss. You can actually pick that up in the blood and in tissue testing. At the moment, it doesn't really have any relevance in kind of if you have an ALK rearrangement in affecting kind of how we treat that. But I will tell you a story that's emerging is CDKN2A and CDKN2B loss predicts for something called MTAP deficiency. And there are some drugs being developed to target MTAP deficient tumors that look really promising in the lab and on paper and in lung cancer. These are moving into studies. So this is not an ALK story. This is kind of a lung cancer story, and it's true in other tumors like GBM. And so right now, CDKN2 on a report isn't going to change kind of what we recommend, but it might predict or help with options down the road for a clinical trial. I think we're getting near the end here, so we'll try to hurry up here. Do you suggest to have ctDNA and CEA tests, kind of a tumor marker, regularly, and how often?
So I currently do not get CA. I know that Dr. Kamage does, but I don't know that I don't know how to incorporate that yet into my clinical use. ctDNA is also in the same realm. Right now, I'm predominantly ordering ctDNA when I'm concerned about progression. We don't really know what it means to get ctDNA if someone is doing well, and if the levels are there. We don't actually know yet what to do with that information. So I don't necessarily order tests unless I think it is something that can be acted on and should be acted on. Should one be concerned about the appearance of ground glass opacities and otherwise stable scans? Does this warrant additional investigations or just surveillance?
Yeah, maybe this is a good one to end on because it speaks to a bigger question of, like, how do you know when therapy stopped working? So for me, if this sounds kind of silly, but if somebody is doing well, feeling well, looking well, and I know scans create anxiety, but if you know that already walking into the office, and I can see people across the office and know that they're doing great, it's unlikely something on a scan is going to change that direction for us. Mm-hmm. Ground glass opacities are not an indication to stop or change things. Obviously, the worry would be pneumonitis, cancer, infection, and we'll want to work that up and address it, but nothing. A scan itself doesn't replace kind of how you're doing and how you're feeling. So if you're breathing well, feeling well, everything's going well otherwise, and we found ground glass opacities, it wouldn't change kind of what we do for you, but we'll want to watch them. Abnormalities in the lung on CTs are very common, and so we're just very quick not to change something that's been working so well based on kind of small changes like that.
Yeah, I just want to say I agree 100%. We see patients have ground glass opacities all the time that then come and go. And so I agree that itself, if you've been doing well otherwise, does not make me think that this is progression. It's just something that we make note of in our next scans. We continue to look at it. But if you're doing well, I think we'll just continue on the current therapy.
Well, thanks. It's fun to do this if it's helping. Sorry if the answers are quick or we're not getting at maybe the question, but I can tell you any of the faculty here, we're all friends. We're always happy to kind of address anything and help anytime if you want to call or email.
Yeah, absolutely. Thank you so much, everyone.